is over. Now I call upon again Dr. Sunil Karan.
So having intubated the patient, now we'll go further down to monitor this patient once the patient is in the ICU. Hemodynamic monitoring is a cornerstone of somebody who is in the intensive care unit, because whatever may be it, invasive, non-invasive, I think without this, the very fact that the patient is in the ICU means he's for monitoring. And yes, in the last 2 decades, ICU has come a long way in terms of technology, in terms of lots of other things that we know today of how to monitor some of our patients. Now, is there evidence for this? As the last speaker also spoke about evidence, there is not much evidence to say that you have to monitor these patients. The only one which seems to have evidence in the intensive care unit today is real-time monitoring of arterial line. Otherwise, a lot of our interventions or a lot of our so-called hemodynamic monitoring systems do not have very, very strong evidence. Now, of course, we can't go hunting for looking for evidence. It's like saying I will put somebody on a ventilator versus not put it on a ventilator. And of course, we will never get ethical clearance for that. But the word of caution here is that we have had some of these invasive hemodynamic devices which have actually tended to show harm in some of the studies, and one of the biggest example for that is the PA catheter, use of PA catheter, which was a rampant practice in the late 80s, early 90s, and somewhere in the middle of the 90s there was one retrospective study which showed that it is probably not a good thing to use PA catheter, but today we know it is safe. There are prospective trials which have shown in the non-pregnant population that it is safe, it is good, but it doesn't add value to the treatment of most of my patients, or at least more than 98% of our patients in the intensive care unit. So what about obstetric critical care patients? Again, low grade evidence, low level evidence, not enough data available, and we have extrapolated a lot of things from general critical care patients down into the obstetric patients to say that maybe hemodynamic monitoring works. Now, what is the goal of having a hemodynamic monitoring? So when we talk about hemodynamic, it is looking at what we call as cardiovascular physiology. So we know that, look at blood pressure, heart rate, cardiac output, so many terms in physiology that we learned about. But the bottom line for all of this is what we are trying to see is looking at what is called as tissue perfusion, tissue hypoxia. Now, if the tissue doesn't function well, the entire body system collapses down, as we all know. So looking at the tissue level is very, very difficult for a practical, clinical, daily, day-to-day sort of practice. And what we look at is what are called as surrogate indicators, or sort of, downstream or upstream variables of the tissue or of the capillary metabolism in a very, very global or an average context. So when you say blood pressure has dropped, it is actually very, very late. It's like, the river takes birth somewhere up in the Himalayas, and you are looking at its effect downstream somewhere in the Gangetic plain. Now, unfortunately, there is no other way I can go up the Himalayas to see what is happening at the tissue level. And that is why most of our markers that we look for when we talk about hemodynamic variables are primarily to do with very, very large global indices. And of course, one of them is, and some of them are what I've already, which I've already put down on the slide. So as I said, there is very limited data in obstetrics to actually understand, to know whether we have to use these in these critically ill patients, or we use this in every other pregnant lady who undergoes common elective surgery, cesarean section, etc. So what is a hemodynamic variable or a monitoring? It is nothing but a measure of one or more variables on a continuous or repeated basis, which will give us an indication of the cardiopulmonary condition, so which I have already spoke about. So ideally, a variable which we measure should be non-invasive, real-time, continuously. It should every beat to beat sort of visibility of that should be there, easily interpretable. If Dr. Suma sees, it should not be different. If I see, it should not be different. So the way we interpret it is very, very important. It should be reasonably accurate, repeatable, and should have minimum inter-observer variability. This is the ideal, but of course, we never live in an ideal world in medicine. And so are these obstetric patients different? Yes, they are, because the cardiovascular physiology, as I told you, is largely different from a non-pregnant population. So we have higher heart rate, which we saw in the last talk. We have higher cardiac output, which we saw in the last talk. The blood pressure has lower, what we call a systemic vascular resistance, so the diastolic pressure is much lower. The mean blood pressure sort of remains the same, but you look at the variation that the diastolic pressure is much, much lower. So there's a lot of changes which happen, and all these changes are something that I see in a standard critical care patient outside the pregnant lady. So therefore, defining these hemodynamic variables in a pregnant lady is very, very different to what I would normally see in a critical care population, and therefore this has to be taken in context when we talk about interpreting many of these hemodynamic variables. So if somebody comes with say vasoplegia, is it because of the pregnant state or is it because of underlying sepsis? Difficult to make out. If somebody comes with an elevated heart rate, what is the reason for that? So we also should understand that the baseline for most of our pregnant obstetric patients who are coming critically ill is actually much, much higher. So whether they are really, really sick or it is just some borderline sickness with the pregnant state coming forward to show up all these changes is something we need to be able to differentiate, and that is where the sometimes it becomes a tricky situation to identify. Now, what are the target groups who would require this kind of monitoring? Most often they are patients who do have cardiac problems. It could be a pre-existing heart valvular problem, newly diagnosed problem, a pregnancy-induced cardiomyopathy, pre-existing cardiomyopathy, sudden cardiovascular collapse, as Dr. Suma mentioned to you about somebody who had amniotic fluid embolism, hypertensive emergencies in pregnancy. These are all conditions where we need either some form of hemodynamic monitoring, whether it is invasive, non-invasive or whatever. Certain pulmonary indications such as severe ARDS, 3-4 years ago, in fact last year also we had a big spurt of H1N1 epidemic which came through, and we did find that the pregnant ladies seemed to be affected the most, and in fact the mortality was much higher in this group of patients. So these are very complex situations that we face in the ICU where we are trying to save 2 lives, and of course as the dictum goes, the priority would always be the mother. And these are some of the places where monitoring the hemodynamic variables does help quite a bit. The third indication is renal indications, where it could be either because of uncontrolled hypertension or there is a borderline cardiac output, there's a borderline heart associated with the renal condition. We see it quite often, severe preeclampsia or severe hypertensive emergencies. There is LV dysfunction because of the hypertensive crisis plus an associated acute renal dysfunction. So these are all situations where we may have to look at, these are all groups which fall under the target group for hemodynamic monitoring, and of course any septic shock occurring in a lady who is pregnant. Now, grossly hemodynamic monitoring methods are classified into non-invasive, semi-invasive, or what we call as less invasive hemodynamic monitors, and severely invasive or invasive monitors, invasive variables. So common things of non-invasive are pulse rates, saturation, skin temperature, capillary refill, usual things, the clinical things associated with some things like your pulse oximeter, heart rate monitoring, ECG monitoring, for example, etc. We also have these days NIBP or non-invasive blood pressure monitoring system. Less invasive ones are, common example is your intra-arterial blood pressure monitoring. There are a couple of other things which I will mention, and the most invasive is of course the Swan-Ganz or the PA catheter. So non-invasive I have already touched upon, very simple thing, you don't have to be, it's something I don't have to highlight much, but bedside echocardiography, it's come a long way in the last 10 years. Critical care to me has changed with the presence of bedside point of care ultrasonography. As Dr. Jose has already spent 15-20 minutes on that, I won't touch much upon that, but this is a very non-invasive, easily learnable, short learning curve sort of a procedure, but the problem with it is it's not continuous, and you need to have repeated assessments to be having a monitoring of the trend. Less invasive things, as I said, intra-arterial blood pressure monitoring. This is just a schematic representation of the same. You insert a short cannula into one of the peripheral arteries, and it goes to a pressure transducer system, which is a fluid-filled pressure transducer system, which converts the pressure signals into electrical signals, and that is actually shown up on the monitor. So this is again real time, good. There are newer indices which we have started looking at, what is called as pulse pressure variation, which would define whether a particular patient is fluid responsive or not. The good old CVP, is it good enough? Definitely not in the critical care setting at least. The sensitivity is very, very poor. In fact, if you look at what we call as the plot diagram of CVP, you find that it is as good as tossing a coin. 50% of the time you get it right, 50% of the time you don't get it right. So it's not really a very good sensitive or a specific modality to identify whether a particular patient is going to be fluid responsive or not. But there is one situation where the CVP is very, very low and has a more than 85 to 90% predictability or sensitivity to show that this particular patient is fluid responsive. So if the CVP is normal or high, doesn't mean anything to me. Especially when somebody is on a ventilator, positive pressure ventilation can change the CVP, and therefore you are actually not being able to reflect the exact changes that happen in the intravascular or the preload compartment. So having a very low CVP, yes, take it by face value. Less than 5 is defined to, shown to improve the sensitivity to more than 90%. So you 9 out of 10 times you get it right. But if it is normal or high, doesn't mean anything. Semi-invasive cardiac output methods are there. This is by using what is called a thermodilution technique, where we have injection of a cold saline through the central line, and you measure the cold saline in the arterial line, which is inserted in one of the central arteries, like the, say, the femoral artery. So the time duration that the cold saline takes to come from there to the artery is measured, and through various complex algorithms, we actually define or derive the cardiac output. So this is a semi-invasive method where we are not using a big Swan-Ganz catheter, but of course this is something which can be considered. Invasive is of course Swan-Ganz catheter, nice one, put through the IJ, goes down into the pulmonary artery catheter, and you get various forms of tracing as it goes from the RA to the RV to the pulmonary artery, and you get the wedge pressure to look at the LV side of things, RV side of things. Very complex, I won't touch up on it, and it is generally not needed. I have not used a Swan-Ganz for the last 10 years, to be honest with you. So just a word on point of care, as I said, useful to assess the LV function. So you just put a probe, good LV, cardiac component ruled out. LV empty, kissing sign, you know that there is hypovolemia. Look at the IVC diameter. There is two indices called as collapsibility index in a spontaneously breathing patient and distensibility index, which Dr. Jose has already touched upon. And we also measure out what is called as the VTI, or the velocity time integral, which is a very simple measure to measure by where we actually measure the flow across the aortic valve. And that gives us a good idea of the stroke volume, and from that we can actually derive the cardiac output. So this is the IVC which is done, and of course Dr. Jose has already shown you how to do that. This is the velocity time integral that I told you. So you put a pulse wave Doppler across the aortic LVOT, the left ventricular outflow tract. You put this Doppler and you actually measure in that fashion the velocity time integral, and this is nothing but the flow which is plotted against the time. And you actually find that if the value is anywhere between 18 to 24, it is normal. You can actually have variations up to 13%, which indicates fluid responsiveness. If it is less than 18, it means the patient is having low cardiac output. Now, whether the low cardiac output is because of the poor LV or because of hypovolemia, you can look at other parameters and decide. So this is a very simple bedside test with a good degree of repeatability and reasonably less inter-observer variation, as long as you get that plot right. So what is the practicality of hemodynamic monitoring in ICU in general, but more so in the obstetric critical care patients? First and foremost, we need to understand it is very poorly validated in the obstetric critical care patients, and whatever we have today is extrapolation from the general critical care population. Yes, there are studies which have been done in hemodynamic variables in a general population of ICU, where there is a very small percentage of patients who have presented with obstetric problems, but there have not been really enough numbers to say that, you know, this is how I'm going to look after this set of patients. Case series shows that there is a utility of very ill patients, like especially when they are having hypertensive emergencies associated with the poor cardiac output and renal dysfunction. Especially in this subgroup of patients, there are certain case series which have shown that there could be benefit of using hemodynamic monitoring. I'm not talking about highly invasive stuff, just about hemodynamic monitoring. Interaction between the physiological variables in the pregnant state and the values in the general population needs to be considered, and you need to understand the baseline for the pregnant lady is much higher, especially when we are talking about cardiovascular variables. And there is a paradigm shift in general intensive care today from invasive to less invasive to nearly non-invasive methods of monitoring, which is definitely going to be much more beneficial for the obstetrical critical care patient, because we don't have to be doing too many things or too many invasive things to just get a simple number and to actually determine the direction of the course of therapy or the course of management. So in summary, methods of hemodynamic monitoring are poorly validated in the pregnant ladies or in the pregnant physiology. Role of the same in subgroup is this subgroup is poorly defined, as I already told you, and very critical patients, especially with the combination of a cardiopulmonary and a renal, there could be a role for hemodynamic monitoring and maybe some form of a semi-invasive monitoring as well. There has been a shifting trend from a very invasive monitoring systems to less invasive to nearly non-invasive methods, and of course ultrasound today has come a long way and seems to have made a certain amount of shift and gives out a certain amount of direction in monitoring many of our patients.